Last thing I want to talk about here is cardiac conduction blood supply. So we've already talked about this. This is my right atrium here, okay? And I'm going to have my SA node, and I'm going to have my AV node, okay, right? So here's my signal connecting here. Then I have my bundle, I have my right and left branch. We're just going to keep things simple. Then I have my right bundle, I have my left bundle. Okay, so this is just going to be kind of just a general depiction here. And I just want to show you the blood supplies here. So the right coronary artery, we kind of already talked about this earlier, but the right coronary artery is going to supply the SA node. It's usually going to supply the AV node, not always, but usually. Okay, and then it can also supply the majority of the bundle of his here. Okay, so the right coronary artery is going to supply a lot of the structures up here. So we're going to write in right coronary artery. It's kind of going to supply this region here, which means if you have an infarction, right, and it's usually going to be an inferior wall infarction if they ask you about this. And if I have an inferior wall infarction, right, classically leads 2, 3, and AVF. That will affect usually the SA node, right, which can cause sick sinus syndrome, can affect the AV node, which can cause AV blocks. The big one we'd be worried about is a 3rd degree block, right? And it can also delay the signal through the bundle down here, proximally, okay? So those are the things that we might be looking for in a patient that had an inferior wall MI. These patients will tend to have bradycardia, right? Because both of these we already talked about typically will present with bradycardia. They'll tend to be preload dependent. They're not going to have a lot of blood returning to the heart. They're going to have a lower cardiac output because their heart rate is so low, okay? And so for that reason, these tend to be preload dependent. We don't want to give them things like nitroglycerin, which would decrease the amount of blood returning to the heart, the venous system. The other piece here in terms of blood supply is the LAD, the left anterior descending artery, which typically can supply the kind of distal portion here of the bundle of his, and then it will also supply the complete left bundle here. Okay, so this is all usually going to be LAD. Now, I left the right bundle out. I'll come back to that in a second. Okay, but so this whole region here is going to tend to be the LAD. So again, if we're talking about leads V1, V2, or V1 to V4, right, this would be very classic for ST elevations in this region, would be very classic for causing a left bundle branch block. So the whole point here is, you know, if you ever get if you're reading an EKG and you see a patient that has something that looks like this in lead V6, okay, right away you have to, usually in those situations, you start to think about an MI because the LAD, the widowmaker, tends to be one of the major vessels that we talk about in infarctions, and it tends to be one of the more commonly affected vessels. That's why a lot of times you'll see in patients that have left bundle branch blocks, this tends to be a very ominous finding for a myocardial infarction. And, you know, in general, people will have a very low threshold for working up these left bundle branch blocks for patients that have chest pain. It tends to be very much correlated with MIs, okay, so that's something to remember. The one that's tricky here is the right bundles can be associated with either the right coronary artery or the left, okay, it just depends on what portion in its course, so we're just going to put it in blue here. It tends to be either one, so it tends to be more nonspecific. Where the right bundle branch blocks come up in questions is usually when a patient has some kind of right heart strain. Like I said, the big one is going to be a PE or pulmonary hypertension, but you can also see it with ASDs, VSDs, tetralogy of Fallot. Like I said, those are all very classic too.